Hi everyone, thanks for listening to my presentations. Today I'll be talking about lower abdominal pain in a young lady. And if you may ask, why limiting myself to young lady? Well, the reason is that anyone could have lower abdominal pain, but any woman of a childbearing age might have situations that will warrant more urgent attention to save their lives. Okay? In other words, there are so many situations in young women, particularly women of childbearing age, that if not addressed so quickly enough, could lead to death. With that in mind, let's go. Okay, what I will be doing today, to those who are familiar with my channel, will be a bit different. I'll just go over the possible differential diagnosis of lower abdominal pain in a young lady. Each will be defined very briefly. It's not going to be, the expected full lecture for each differential diagnosis, because I'll be going through about 25 to 30 differential diagnoses within 30 minutes. Each could be taken as a full lecture later on. But if you check my channel, I have already published about 7 of them. The rest will be for the future. Okay, have that at the back of your mind that you are going to get just brief pieces of info that will distinguish each of the differential diagnoses, not details. Okay, less than 30 minutes, we're going over about 25 to 30 differential diagnoses. Okay, sit back and let's go. Okay, if a woman of childbearing age is having lower abdominal pain, we need to find out the last menstrual period. Okay, the onset and when it ended. Are there pregnancy symptoms? We'll go over all of them. History of past pregnancies. If she had pregnancies in the past, we must know. Okay, is there bleeding now or not associated with this pain? Because ectopic pregnancy could have concealed bleeding, meaning the woman will not be able to tell specifically that she's bleeding, so it is concealed, but most times it's not. Okay, any radiation of the pain, particularly ectopic pregnancy, could radiate to the shoulder. Okay, if the woman is known to be pregnant, well, at the first trimester, then we might be dealing with threatened abortion, in which case the abdominal pain will not be so horrible and bleeding will be minimal. And one significant thing here is that the cervix is closed. Ultrasound will also confirm the viability of the fetus. Then that is threatening abortion and will manage appropriately. In the case of inevitable abortion, there is more pain, more bleeding, the cervix is open. In that case, there's nothing we can do to save that pregnancy. That is inevitable abortion and will treat appropriately. Of course, we'll call for ultrasound as well. In the case of complete abortion, the history of the pain will likely have occurred and the pain might have subsided. And the product of conception would have been seen by the woman, but we can't blame her if she doesn't know exactly what she was dealing with. Okay, the history, the bleeding, the pain, the product of conception seen, then we'll have ultrasound done that will confirm that nothing is there anymore. In the case of incomplete abortion, pain, bleeding, cervix open, part of the product of conception already out, parts still retained. Well, we'll need ultrasound for medical legal reasons to be able to back her decision. Then will help the woman to get the remaining parts of the product of conception out. Sometimes women are pregnant at the same time when they have fibroid, and the fibroid will undergo red degeneration when it's associated with pregnancy, and that will lead to serious pain. Of course, we'll manage that pain and the pregnancy together. It could be later part of the pregnancy, then we'll be dealing with placenta previa. Now, it could be painless and then be bleeding. We'll have ultrasound done that will establish the position of the placenta. If it is early in the pregnancy, we can repeat the ultrasound at 36 weeks and above, and wherever the placenta is at that time, that is how the pregnancy will end. Okay. In the case of approachable placenta, there will be pain, and it's likely that we're not going to peak fetal activities. We'll have ultrasound done to confirm the viability of the fetus, right? Then the bleeding could be massive or could be concealed sometimes, okay? It could be labor. In that case, there'll be off and on, waxing and waning, contraction of the uterus, giving pain, and we'll see some other signs. The cervix will be dilating progressively, and then we'll be able to tell the woman this is a good news. The pain is not for anything bad. It's the end of the road. The baby is about to come out. And of course, so many other things will be involved. Maybe you need augmentation or not. That will be done. So if it is labor related and there is uterine rupture, then that's an acute emergency. Okay, so this is one of those reasons why I'm making this presentation. Okay, is this pelvic inflammatory disease now giving us peritonitis? Onset, cause, duration, the discharge, what is the color, what is the odor, what is the quantity? Is it stained with blood? I need to find out. Any fever here, and how severe is this? Nausea or vomiting? And of course, in any woman of childbearing age, we need to know the last time she had a menses, last menstrual period. Is this PID related to pregnancy? Is it associated with pregnancy? We want to establish that. Now, we will delve into the social life of this woman a bit, but respectively anyway. Monogamy or polygamy? Safe sex being practiced or not? History of STI in this woman or in a partner? And of course, is IUD in place? Because IUD is even contraindicated in any woman that is not keeping monogamy, a kind of relationship, and with history of PID, no IUD. But in case there's IUD in place, this is going to worsen the situation, right? Or the woman has just removed the IUD, okay? We need to find out. Okay, is this cholelithiasis, gallstone? Okay. Pain is increasing with fatty meals. Oh, yeah. Tumor of the ampulla here or not? We have our ultrasound done, right? Okay. And then we have what is called 5Fs, which is not going to follow in that direction all the time, right? Fair complexion, in 5th decade of life, 40-something. Of course, we are dealing with a female, right? Is she fertile, has given birth to kids before, and is she fat? I'm not saying we have to dogmatically follow this, no, because we've seen women who don't even belong to 3 of these 5, and yet they are down with cholelithiasis, okay? Okay, intestinal obstruction. Have you passed gas today? What is your bowel movement like? Any nausea or vomiting? Past surgery, because addition is the common cause of small bowel obstruction. So past surgery, is very helpful here. I mean the history of it, okay? Then any gastrointestinal cancer already diagnosed before now, we need to know. And of course, appropriate radiological investigation, barium, endoscopy, or ultrasound, and sigmoidoscopy, colonoscopy, as the case might be. Okay, could this be appendicitis? Any fever here, any loss of appetite, and the pain here will start at periumbilical region and then later on localize to the right iliac fossa, but not all the times, right? Because we might have pelvic appendix. No, it's not all the time that it's going to be at right iliac fossa. But on physical examination, with the fever, with the pain, with nausea and vomiting, then we have our Rosen sign done. Swell sign, obturator, then we can have our CT scan on top of that. But in many parts of the world, without CT scan, diagnosis of appendicitis could be made easily clinically. Peptic ulcer disease. Yeah. Any stress in your life recently? Any use of non-steroidal anti-inflammatory drug like ibuprofen or aspirin? Have you been on steroid for a long period of time? Any hunger, for a long time, maybe hunger strike? Have you ever been diagnosed with H. pylori in any way? Have you ever been diagnosed with peptic ulcer disease? So we rule out all this because we might be dealing with peritonitis secondary to peptic ulcer disease perforation right now. Could this be myocardial infarction? Chest pain, shortness of breath, diaphoresis, pressure-like effect, Levine sign at the chest region? Want to find out? I have separate presentation on myocardial infarction on my channel, about 6 presentations already published. You can check heart attack on my channel for that. History of medications, lipid, diabetes, hypertension, stroke, atrial fibrillation, and so on. Everything that is associated with possible myocardial infarction, because we have to rule out modifiable and non-modifiable risk factors, and then make our diagnosis with EKG, cardiac enzymes, and all other investigations to support that. Okay, we might be dealing with kidney stone, otherwise known as nephrolithiasis, and it might be pyelonephritis. And these 2 cases will warrant urgent action, particularly pyelonephritis. Okay, that will lead us to history of passage of stone in the urine, any pain, and describe the characteristics of the pain. I'll go into that in a bit. Blood in urine, dysuria, that is pain when the individual micturates or pees. Nocturia, that is pee more at night and not having diabetes mellitus or diabetes insipidus and not on diuretics. Any associated fever, and how high is the fever? Nausea and vomiting. And of course, when the diagnosis is pyelonephritis, just as the case is with kidney stone, it is an emergency, but more in pyelonephritis. We need to act faster. Pancreatitis or pancreatic cancer. Well, any pancreatic disease in you, is your stool floating or difficult to flush? That is tertiary, right? Any loss of weight that is not intentional, that's pointing to cancer, right? any indigestion or malabsorption that is pointing to problem with the pancreas because the enzymes are not being released to have complete digestion, right? Any glucose metabolism anomalies, because when the pancreas is under insult, then you can be rest assured that insulin will be in trouble as well. Okay, this woman is on IUD. Oh my goodness. Are we dealing with IUD perforation of the uterus? We're not sure. Okay, the history of IUD, is it there? When was it inserted? Can you feel the tail right now? What type is it? Is it entered or lost? Are we dealing with uterine perforation here? Any bleeding? Let's get ultrasound done, please. When was your last menstrual period, if at all? If she's still menstruating, can you rule out ectopic pregnancy in this woman? Because if no, she is by accident pregnant and there's entered IUD, the likelihood of having ectopic pregnancy is higher. Okay, and if there's by chance there's uterine pregnancy, we rule that out with ultrasound. Oh, we can have abdominal pelvic X-ray done to find out where the IUD is, if it is lost. In fact, you can insert another one so that you'll be able to see the two and be double sure the other one is actually lost. Okay, inflammatory bowel disease, example, ulcerative colitis. Any autoimmune disease here, you know what? Once there is diagnosis of one autoimmune disease, be on the lookout for more, okay? That is the rule. And that is the golden rule when it comes to autoimmune disease. You pick one autoimmune disease, you are likely going to find more autoimmune diseases. So ulcerative colitis, Crohn's disease, then if this woman is having problem with her thyroid, I won't be shocked, okay? Hashimoto's thyroiditis is possible like this, or Graves' disease, or celiac disease, or systemic lupus erythematosus, or type 1 diabetes mellitus, or rheumatoid arthritis, Sjögren's syndrome, or could show up here. Okay, we need to find out if this pain is related to accident, or could this be an abuse. We must be careful because spousal abuse is very possible, particularly in a young woman in first pregnancy without experience by both the wife and the husband. The rate of abuse is very high in that particular setting. I have a separate presentation already published as per intimate partners violence or spousal abuse. You can check my channel for that. But it is a very serious diagnosis that we must not miss. Okay, could this be Reiter syndrome? No safe sex, multiple partners, any vaginal discharge, any eye discharge, conjunctivitis, any joint pains affecting many joints, rashes. Have you ever had history of salmonella recently or chlamydia trachomatis diagnosed recently? Any other sexually transmitted infection in you or in your partner? Any sore throat? Any lumps in your body, meaning lymph nodes enlargement? We need to find out. Okay, could this be ruptured ovarian cyst? We need to know the onset, the cause, the duration of the pain, and of course the severity. And is this the flank? Can you point at the very flank? Any pain when you pee, any pain when you have relationship, any abdominal swelling associated with this, and of course we will not forget the last menstrual period and history of menstruation generally, whether it is regular or not. Okay, we've gone around many differential diagnoses, and we're about going down on a very specific diagnosis, and that will warrant more history and, of course, very thorough one, asking appropriate questions. Then the pain will be in the center of it because we're talking about lower abdominal pain, right? Okay, onset, the cause, duration, and of course, since this is in a young woman, we want to know about history of intrauterine device in place. Any oral contraceptive now being prescribed and being taken. Of course, first thing first, last menstrual period, because we have to rule out pregnancy. Past medical history, family history, and of course, past hospitalization. Okay, we will then dwell more on the pain itself. Okay, the pain-related questions will go as the onset of the pain, palliative, that is, what makes it better, what relieves you, aggravate, what makes it worse. Can you use one finger to point at the site of the pain and any radiation? You want to know the quality of that pain and, of course, severity on a scale of 1 to 10, with 1 being the mildest and 10 being the worst. The timing of the pain and what is the understanding as per the cause of this pain. Is it associated with vomiting, and is it associated with unintended weight loss? Okay, with medical ethics in mind and the boundary and of course the limitations, we will delve cautiously but precisely into social history. That will involve marriage, living condition, the occupation, smoking, alcohol, drugs, diet, exercise, stress, and of course, sexual activity. Okay, when it comes to the physical examination, though the problem is abdominal in origin, because we're dealing with lower abdominal pain, right? But we'll start by having general inspection of the entire system. Okay, from head to just general examination. We'll be careful because we're dealing with females, right? So you can have a chaperone, and of course, just don't expose anyhow, right? So inspection generally, the look and everything like that. Then we'll then start other inspection from the facial region. We'll check for redness, discharge, check the mount for angular stomatitis, the ends, because the ends could be the window to the entire body system. We check for lymph nodes, now the head and neck region, and is the abdomen moving with respiration, any scar, any distension, and what is the position, the umbilicus, inverted or everted, and so on. Okay, because this is abdominal examination, from inspection, we'll move straight to auscultation. Then we'll have bowel sound at the lower quadrant on the right. Okay, we want to know whether it's normal, hypo, or hyper active. Okay, when it comes to percussion, of course, we'll go around all the quadrants, but specifically, we want to know what's happening to the spleen, right? Whether we're dealing with splenomegaly or hepatomegaly. So, we'll start when it comes to spleen for splenic donors from the right iliac fossa, going to the left coastal margin. And we can have castecine at trabeal space. Liver donors from lower right hypochondrial part, up, then percuss for donors there, right? All quadrant, and we know the percussion tenderness, and in fact, we are going to elicit some signs that I'm going to in a bit. We can have shifting donors done when there is flank donors suggestive of fluid, and at the same time, we can have fluid tree done. Okay, peritoneal signs. That is, we want to know if we are dealing with peritonitis here or not. And that will involve abdominal tenderness, rigidity, guarding, rebound tenderness, and ultrasound probe tenderness. And of course, we'll ask about the history of road bumping tenderness. That is, on your way to the hospital with the EMS, emergency medical services, payphone, and ambulance, were you feeling pain anytime there was road bumping? Okay, we need to find out. Okay, there are other special tests that could be done. When it comes to the appendix, we can have Rosen sign, Mahoney sign, Sewer sign, and obturator sign. Okay. Then Murphy sign will be helpful when we are thinking about differential diagnosis of cholelithiasis because it is specifically positive in the phase of cholecystitis. Cassette sign and trabeal space will help us with splenomegaly. And of course, Peritoneal sign will reveal retroperitoneal hemorrhage. Coolant sign at the periumbilical region will give us a clue to ectopic pregnancy, but that doesn't mean when it is absent that it is not ectopic pregnancy. No. But when it is present, it might give us a clue to ectopic pregnancy, but it is not specific to ectopic pregnancy. It could be anything else there. Costovertebral angle tenderness will give us a clue to what is happening to the kidney, particularly when we're trying to rule out pyelonephritis or nephrolithiasis. Okay, we have to carry out certain investigations, and that will be determined by the diagnosis we have in mind. But first thing first, beta human chorionic gonadotrophin in all women of childbearing age. Just yes or no value. Just want to be sure we're dealing with pregnancy or not. Ultrasound will be welcome here. Even if she's pregnant, that would be great. We need ultrasound. High vaginal swell for microscopy culture sensitivity, particularly when we're suspecting pelvic inflammatory disease. We can have a complete blood count done. We can have urinalysis. We can have urine NCS done. And of course, we have amylase or lipase when we are suspecting pancreatitis. Liver function test, and of course, complete renal function tests, including blood urea nitrogen, creatinine, and electrolytes. Okay, when it comes to treatment, it's going to be definitive treatment based on definitive diagnosis. All I've done is to bring it to our awareness that a young woman of childbearing age having lower abdominal pain could have many different diagnoses, okay? Many differentials. So with the history, with physical examination, with our laboratory investigations, radiological investigations, it may be appropriate, we will have a definitive diagnosis and then have definitive treatment. Referral may be appropriate depending on the diagnosis. And with that, I've come to the end of this presentation. So a young woman of childbearing age with lower abdominal pain, we know what to do. Thanks for listening. Remember to share, remember to subscribe, and you are free to leave comment on my channel. I appreciate it.